Thank you. Welcome to this meeting of the Joint Committee. As in recent meetings, we did have a short pre-briefing with members of the public to try and explain how the agenda was formulated and what the key issues were. I hope they found that useful and we got some useful feedback. So thank you very much to members of the public for that. We will have time at the end of the meeting for a few questions from members of the public. If it's a matter that can be dealt with by an individual member of the committee later in person, if it's a detailed question, we'll deal with it that way. But we will have a short period for general questions for matters that arise during the meeting, but I'll only be taking questions on items that are on this agenda. I hope that's clear. We do have papers, again, hard copies for members of the public which have been distributed, and also we hope that members of the public find this venue user-friendly. We've done our best to find locations, and this tends to be, from what the feedback we've had, one of the better ones for members of the public and also for members of the committee to contribute to the debate. So that's why we're here again. Just a few housekeeping points. There's no fire drill expected. The fire exits are through the two doors at the back and out in that direction. The usual thing about mobile phones, can we switch them off, including myself? First of all, I will ask members of the committee to, I know there are signs in front of us, but perhaps not be easy to be read from the back. So if we can start in the corner there and work our way around, just very briefly saying who we are. Thank you.
I'm Linda Riley, Director of Operations for Midlands and Lancashire Commissioning Support Unit.
Morecambe Bay CCG.
Amanda Doyle, I'm the Chief Officer for the ICS and the Chief Officer for the two Falco CCGs.
I'm Neil Greaves, I'm the Communications and Engagement Lead for Healthier Lancashire and South Cumbria.
I'm Executive Assistant, East Lancashire and South Cumbria.
Andrew Bennett, Director of Commissioning for Healthier Lancashire and South Cumbria.
Phil Watson, I'm the independent chair of this joint committee.
Rebecca Higgs, I'm the Policy Development Manager at Midlands and Lancashire Commissioning Support Unit.
Thank you. Elaine Johnston, I'm the Chair of the Lancashire and South Cumbria Commissioning Policy Development Group. I'm here to present Agenda Item 6.
Hello, I'm Julie Higgins. I'm the Chief Officer for East Lancashire and Blackburn with Darwen CCGs.
Hello, Roy Fisher, Chair of Blackpool CCG.
Steve Thompson, Director of Resources, Blackpool Council, representing Neil Jack, who's our Chief Executive.
Doug Soper, lay member at West Lancashire CCG.
Paul Kingan, Chief Finance Officer for West Lancs CCG.
Hello, my name is Andy Kern, Medical Director for the ICS.
Jeff Jolliffe, GP Chair, Morecambe Bay CCG.
Thank you very much. Just to say also, you probably noticed with the camera in the middle and so on that the meeting is being live streamed as in previous meetings, so just so that you're aware of that. So moving on to the second item on the agenda, it's declarations of interest. Are there any declarations of interest to be declared at this time? No, thank you very much. We then move on to the notes of the meeting held on the 1st of November. I'll go through it quickly page by page if there are any alterations or amendments or corrections. Page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8. So I will sign those as the correct record of the meeting on your behalf. Thank you very much. Are there any other items of any other business that we can deal with later on the agenda? Andrew.
So, Chair, I have a very brief verbal item about the work programme for the committee, which I hope we could deal with under any other business, please.
Thank you. And was there one other, I think, Elaine?
Yes, I have again also a very brief verbal update around one of our policies, which I would like to do at the end of the policy section, if that is sensible.
Okay, thank you very much. So those are two items. The one Andrew mentioned at the end of the meeting, and the one that Elaine has just mentioned will be dealt with at the end of item 6, if that's acceptable to colleagues. Thank you. So we move on to, with two substantial items today. The first one is the NHS long-term plan and later commissioning policies. So the NHS long-term plan, Dr. Amanda Doyle will give a presentation. Thank you.
Thank you. As everybody is aware, the long-term plan was published at the beginning of January this year, after much anticipation. And people will have within their own organisations, I'm absolutely sure, have discussed this and looked at it and looked at the implications. But there is an expectation that we, as a integrated care system across Lancashire and South Cumbria, have a plan for how we will implement the asks of this across our whole system. And the integrated care system's in the process of developing a strategic plan for how we will go about this. And there is an expectation also that we share that and involve the public and our communities in what that plan looks like. This is the first opportunity we've had to discuss the implications of some of the key points of the long-term plan in public as a group of CCGs, as opposed to what we will each have done in our own organisations. And so, although it may feel like a repeat, it's really important that we think about the system-wide implications for how we approach this. It's a thick document with lots and lots of in it, and lots of asks and lots of details. So I'm going to pick out some of the key points that we need to understand and be aware of. This item is really for discussion. Quite happy to be interrupted or for people to wait to the end about the points that are relevant for us as a system and that we might want to pick up. So as I say, don't hesitate to interrupt. So, this came about when the government was asked for more long-term funding for the NHS to enable us to make the services sustainable and to continue to transform them. The government committed to £20.5 billion per year extra at the end of 5 years, but contingent upon the NHS itself coming up with a plan for how this would be spent and how we would use this money to demonstrate improvement in the services we were offering, but also the overall health outcomes for our population. And that's what this plan is. So the second third or so of last year was spent by a significant group of people nationally, involving a whole range of stakeholders, including patient voices and representatives of patient groups, either disease-specific or more general, as well as commissioners, providers, the think tanks, and a whole range of people. And this is what they came up with. It really reinforces the importance of organisations working together to join up and integrate services at every level of the system. So at neighbourhood level, at place level, and at system level, which is absolutely the approach we've taken and the direction of travel we've been moving in. So none of that is new to us or a challenge for us. It fits really well with our existing strategy and plans. There's much stronger action required to tackle health inequalities. So we all have previously talked a lot about health inequalities, but we haven't particularly either been incentivised or focused particularly around tackling and narrowing these health inequalities. There's an ask that we do that. It's really, really relevant in this part of the country where there is some patches of extreme deprivation and extreme inequality. But that is actually supported by targeted funding, and that's really apparent when you look at different CCG allocations where extra money is going into areas where investment is needed to tackle the health impact of extreme deprivation. There's much welcomed increased investment in primary and community care to expand neighbourhood teams, and then there's some key clinical priority areas where there's focus on either transforming or developing services or improving delivery. And those are, as we would expect, there's no surprises here, cancer, mental health, learning disability, autism, diabetes, stroke and children's health. And some of those we're already starting to see some of that coming out and coming through into delivery. So we're lucky in that 2 parts of our patch, Blackburn with Darwen and Blackpool, are part of the early diagnosis of lung cancer pilot, where we'll be proactively screening middle-aged and elderly smokers or ex-smokers to improve early diagnosis. And that's a key part of the cancer part of the long-term plan. There are, and there's been a lot of discussion, and people will have picked it up in the press, around the health inequalities action, and particularly the focus on prevention. And you remember that since 2012, commissioning of preventative services, so smoking, substance misuse, alcohol services, those sorts of things, has been the responsibility of the local authorities. And yet, in a long-term plan for the NHS, we are seeing targeted funding going into health commissioners to commission services to improve prevention. That's very deliberately aimed at not taking over any of the local authority responsibilities, but recognising that there are some components of the prevention agenda which very much need delivering by or through the NHS. So smoking cessation, commissioning is a local authority responsibility, but this is targeted at how we increase uptake of smoking cessation in hospital inpatients and in people who are in our services. Identification and treatment of high blood pressure is a key aspect of improving cardiovascular health and of improving life expectancy. Secondary prevention of stroke through management of atrial fibrillation. So those sorts of things are explicitly NHS actions to complement local authority work. And then there are the wider determinants of health which the NHS needs to have a voice around tackling. So the bigger issues which need to be tackled by government around big campaigns, air pollution, housing, traffic policy, those sorts of things. We are expected to set out how we will reduce inequalities both in access to and outcomes from health services. And we also are expected to demonstrate how we will do more to support people with learning disabilities and autism, and to ensure that we improve the physical health of people with long-term mental health conditions, which is known to be a really poor, and leads to really poor outcomes. And there's more support there for carers. Primary care is a big winner, for want of a better term. There's a recognition that unless we make the primary care system sustainable, we're not going to make the whole system sustainable, and it's really, really important as demand rises and the population changes that we invest in those out-of-hospital primary and community services which support an ageing population with multiple long-term conditions to stay well for longer. £4.5 billion of increased funding over 5 years is going into primary care, largely through significant changes to the GMS contract, which will include from this summer a network contract designed to support the uptake and delivery of primary care networks, which are the GP component of our neighbourhoods. Fortunately, we are well on the way to having delivered neighbourhoods. We've got 41 across Lancashire and South Cumbria, although that number's likely to shrink a little bit. And there's significant and substantial funding going into primary care networks through the network contract designed to support some of these priority areas in the long-term plan. There is an increased emphasis on, again, through primary care networks and community services, urgent community response services and recovery services, much greater and more explicit support to care homes through a care home component of the network contract, and some changes to the quality and outcomes framework with a retirement of a lot of the indicators but an increased focus on quality improvement in primary care. There's expansion of urgent care services and an attempt to bring those together through 111 as a single point of access with a clinical assessment service embedded within 111, providing multidisciplinary assessment, and with the expectation that 111 is able to book directly into both in-hours and out-of-hours GP services from this year. A&E departments will have embedded within the service model some of the things that evidence has shown makes a difference. So comprehensive same-day emergency care services, so assess and treat services, frailty services, and a continued focus on reducing delayed discharges with local authorities. Big focus on end-of-life care, a real focus on personalisation. This includes a rollout of personal health budgets, but includes much more around the stuff we're doing in the population health management approach we're taking around using the information we already know about our patients better to personalise and make their care more proactive, so risk stratification, identification of risk in individuals as well as in communities, and widening access to social prescribing. There's funding for social prescribing workers in every network. Emphasis on digital. Patients will have a new right to choose either telephone or online consulting as well as face-to-face consulting. There will be a digital NHS front door through the NHS app, which is currently being rolled out. So people will be able to not only access services such as their GP service or signposting to other services, but also will be able to symptom check and get advice through that. And there's an ask that we redesign outpatients to make better use of technology instead of dragging people up to sit in clinics. It's also an area that's ripe for some efficiency gains to enable us to invest more in some of these new services we want to invest in. Talked about those, real focus on the key priority clinical areas, and some of these are coming online now, as I described with the council. Some of it's coming online in a staged way over the next couple of years. And a real focus on children's health and a healthy start in life, which again fits with the work we've done so far around our prioritisation and the work Arif and others have been leading about children. Talks about integrated care systems, reinforces the fact that integrated care systems are absolutely central to the system architecture in the future. Talks about commissioning arrangements. There is an expectation that ICS has moved to much more streamlined commissioning arrangements with a single set of commissioning arrangements at system level, so Lancashire and South Cumbria for us. And it says it will typically involve a single CCG for each ICS area. Those CCGs will become leaner and more strategic, and an increasing number of the decision-making, this is a big change, will be made jointly by providers and commissioners, with only those decisions which statutorily have to be taken by separate commissioning organisations continuing to be the responsibility of CCGs. This again fits very much with what's actually happening on the ground in this patch, in that we are increasingly working closely with local providers to jointly plan and make decisions around our strategy and delivery. A push on staff, so increase the workforce we've got by training more people, focusing on recruitment and retention, and a focus on making the NHS a better place to work. No amount of recruitment and retention schemes will do anything unless we make these jobs people want to do and want to continue to do for most of their working life. But there will be thousands more clinical placements, both at undergraduate and postgraduate level, for not only medical school places, but nursing places, therapy places, better use of the apprenticeship levy. And there is an NHS workforce strategy to complement the long-term plan, which is due out at the end of this month. New approach around talent management and leadership development, and again, another push from the successful work we've seen last year around volunteering. Again, digital first primary care, accessing both appointments and clinicians digitally, population health management, using what we know about people, the information we already have, in order to target care more effectively, and not just to assure ourselves and to plan, but to actually improve health. And integrated diagnostic networks to enable faster diagnosis of conditions, and that's particularly around cancer pathways and things like that. We are expected to do this in the resource available, and there's an absolute must to get the NHS back into financial balance by 23-24, which is the end of this 5-year period. There are asks around productivity savings, and some of the rules around financial business are being changed to incentivise a more rapid movement to financial balance, and we're seeing that playing out with the way the control totals have been applied this year to our providers. And that's what the transitional year this year is, and we are expecting for next year further financial reforms, and also an ICS-wide accountability and performance framework. So we have been given an ICS system control total, which is simply the sum of the control totals of the constituent organisations, whether or not those organisations have accepted them. So the next steps for us, we have to produce a Lancashire and South Cumbria plan to implement the commitments in the 5-year plan locally, and that will be the ICS 5-year strategic plan. We have to engage with our partners and with the public and patients to do that. And then we will continue the work we've been doing. As you know, we are a first wave integrated care system, and so a lot of the stuff that's completely new to some patches are things we've already been working on, and we need to continue and ramp up some of that work. And probably since these slides we're doing, the consultation has now been published over the legislative ask to support this work. So there is a limited number of legislative changes that aren't essential to do some of this, will just make it much quicker and easier to do some of it. And so some of those things are around not only duties to collaborate, but moving away from a complete purchaser-provider split, allowing formalisation of integrated care services. And that's about it. I'm happy to answer any questions, but actually really what we needed is a discussion about people's views about how we come up with this plan, how we do the level of engagement required, and what a sense from the various parts of the patch is around the response to this.
Okay, thank you, Amanda. Any comments? Yeah.
I suppose one of the questions for me, Amanda, is that when we talk about engagement on the NHS 10-year plan, how that links into the engagement and consultation programmes that will be taking place across the patch for integrated care partnerships, so that, I don't know how to put this, so that in a sense the two don't muddy each other and we trip over, because I would imagine, for example, that the plans of the integrated care partnerships at the local level will take account of what the aims and objectives of the NHS 10-year plan are.
So they will, but actually so we're not so much consulting or engaging on the plan in as much as that's out and published and feedback has been taken. What we need to involve people in is how are we implementing that locally. Now, the geography on which a plan to implement locally has to be consulted on, engaged on, published, is Lancashire and South Cumbria. We recognise that within that there are 5 local places that also are going to have to do some of that. What it can't be is separate plans, and the Lancashire and South Cumbria one also can't be sticking together 5 separate ones. So we have to be aware of that risk, but make sure we manage it.
Doug?
Yeah, thanks. I mean, there's lots of aspirations within this plan, although some of them to me appear to be a little vague in terms of hard targets. It's clear in recent years that we've struggled to maintain adequate waiting times, and the waiting times at the moment, both in primary care and secondary care, are basically unacceptable in many cases. Combined with that, we've got Lord Pryor, who's chair of NHSE, making comments about ditching some of the existing waiting time targets. And I don't know whether that's actually going to happen or whether it's under consideration. But how are you going to hold the different systems across Lancashire, and the hospitals in particular, to account to deliver? How are you going to measure their performance without hard targets on areas such as waiting times?
The first point, you know, some of it is vague. This is a strategy document. The NHSE and I are currently producing, and it will be out fairly soon, I think, an implementation plan for this. And that's where some of the detail will be around what expectations are, pace of improvement, targets, all of that sort of thing. So that's that. This was never intended to have all the detail. There's an accompanying implementation plan coming shortly. There is a review being led by Steve Powis, who's the National Medical Director, into all of the constitutional targets. It's not about ditching the targets, it's about refining some of them and making them more meaningful. What it's absolutely not is making it easier, so it's easier for us to achieve. So some of them may be changed, but it's likely, and I haven't seen the stuff that's going to come out, it's likely they will be changed to be more specific. So A&E target, for example, may not be a catch-all 4-hour, but may have different objectives depending on the severity of the condition. So there are some conditions which you would expect people to be seen and treated in a much, much shorter time than 4 hours. And there are some conditions for which 4 hours doesn't make any difference to the outcome. And so it's more going to be about making them more meaningful, absolutely not to ditch them. And I wouldn't be supporting us not taking account of some of those targets, because they're there for a reason. Just because we are struggling to deliver them doesn't mean they're not important. The ICS will still have to assure the NHSE and I region as our regulators over our delivery of constitutional and other targets in the same way that we do now. It's just likely that in any patch, the assurance is a combined provider and commissioner assurance. It's not just up to a single provider or a single organisation. But those sorts of things aren't going to change.
Jeff indicated, then Jerry. Is there anybody else that wants to speak? Please. Samantha. And Steve, right. Jeff first.
Well, I hope you're not going to say the same thing as me, Jerry. I just wanted to state what is probably very obvious, but then ask the question, how do we sort this? And that is, if you put more resources into a system and you don't change the model of care and the way you do things, you're likely to just slowly fill up the extra capacity you have and then get the same outcomes. So there has to be a change in the way we deliver things. So that's the obvious thing. And there's a corollary, the other side of the coin to that is, we're putting extra capacity in, but I don't see much in the plan about how we reduce demand in a reasonable way for the public. I don't mean in an unreasonable way. Yeah. So I see a lot of extra capacity. I don't see that side. So how do we make sure that we get that change in the model of care when this money is rolled out, and how do we also do something that's not in the national plan about making sure we reduce that demand in a way that's appropriate?
I mean, you're absolutely right. There's a couple of things, and a lot of this will be is what we're working on our population health management approach. So there's two things. It sounds like a lot of money. 20 billion, well, arguably 20 billion is a lot of money. Yeah. When you break it down to what we get locally and you work out what we're already committed to, so we've already got a gap and there's a load of asks and people are getting a pay rise for the first time in several years and et cetera, we've already spent the increased allocation. So we still haven't got any spare money. Yeah. And so we absolutely, none of this enables us to sit back, breathe a sigh of relief and carry on as usual. Yeah. This absolutely only works if we do it in conjunction with improving efficiency, being more effective, managing demand better and changing the model of care. The other thing is that in our aims to improve health and well-being, to improve clinical outcomes and to do it within the resources available, the reason we're not actually succeeding in doing those things, you're right, is we haven't got enough capacity to meet rising demand, and we will never have, no matter how much money gets poured in, if we don't change our model. Demand is rising at such a rate that, you know, the number of over 85s has trebled in the last 40 years. It's due to increase another 15% in the next 5 years. Those are individuals with multiple long-term conditions, and the old model of diagnose, treat, cure, discharge just doesn't work, and it won't work. That's a population we need to manage long-term conditions, maintain independently, keep them as well as possible, enhance quality of life with independence and keep people able to manage in their own home. And that's the only way we're going to reduce demand. In addition to that, we know that 40% of our disease burden is modifiable or preventable. And if we really seriously want to tackle demand, we need to start to look at that 40%. And it isn't rocket science, but it isn't things we can prescribe for people either, largely. It's things we have to get people interested and involved enough in wanting to improve their health to do for themselves. And, you know, it's don't smoke, drink less, get thin, exercise more, get your blood pressure checked, know about what the risk factors are, and take responsibility for your health. And we can only do that alongside our community. And unless our community know enough about what matters and what's important and what they can do and what their risk is and how to get support, then and all of that is encompassed in trying to balance this demand and capacity equation. And actually our approach to population health management is going to be key to that. This is not spare money. This is going a little way to solving a really pressing problem for the next couple of years.
Joe?
No, it won't. I have loud enough voice. I suppose first I'll start with a sense of optimism. I think there's much in the NHS plan which I think many people will actually say that's what we've been trying to achieve for some time, that's what our ambition is. So I think there is a sense of optimism around that. Just building on Amanda's comment then, I think one thing that perhaps gets overseen in this, and just the level of expectation about people who work in the NHS, people who use the NHS, about the level of change in the way we work and how we behave. And I think it's perhaps something that we have to be cognizant of. So when we're really looking to address inequalities and to improve people's well-being, the responsibility of individuals to think differently, behave differently. If we're going to take a fundamental shift towards neighbourhood teams and getting decisions made in the community, again a change in behaviour for what the NHS has worked really over the last 10 or 15 years. But again, back to actually some of our behaviours, is the recognition that if you go to your general practice, you're not always going to see a GP. Actually, in the future, you may be going to see a range of different care professionals. So I think there are many really attractive and exciting, ambitious things in the NHS plan, but the scale of change in terms of how the NHS behaves and how the NHS has a relationship with its public is perhaps the most significant challenge that we will have to think about and address over the next 5 year to 10 year time within the long-term plan.
Thanks, Samantha. Thank you for the gist. That was really good. I understand about reducing demand and inappropriate demand, and it's a fact of life, as you said, that we are living longer, and therefore we tend to acquire more and more problems as we live longer, and we have to live within our means. Having said all that, I really worry about the workforce. It's a major issue, and it is not just that we don't have enough, it is also that we have less than what we had 5 years ago. And also, from here, looking at the medical press and all sorts of other places, I can see that a lot of people are going to, health personnel are going to retire earlier than they had envisaged, or they are actually trying to reduce their work because of the pensions and all that sort of situation. I remember attending a workforce summit, I think that was last year, which you chaired. I thought that was a very good sort of start. But I really would like something more to happen. We need to have a strategy across the ICS about our workforce, because it doesn't matter how much money or less or more we have to throw, unless we have the workforce, we won't be able to do what we want to do.
No, absolutely agree, and if we had to pick a single biggest problem, it isn't money, it's workforce. We are developing a workforce strategy, and Paula Rolls is leading on that for us. But it can't be something that someone writes a strategy and we put in a box and tick workforce strategy. It needs every single one of our organisations and teams to be thinking about what workforce they will need for the model of care they would want to deliver, and how they're going to get them and where they're going to come from and what do we need to do to train them. But it's back to no amount of thinking of ways to recruit people or stop people retiring will work unless we make these jobs that people want to do. And that means work in services that are sustainable, that give them job satisfaction, that enable people to feel as though they're doing what they trained to do, which is work in a healthcare environment where they are offering high quality care and where they are able to help people get better. So all of that's important. It's not just what people in workforce departments are doing. The national strategy recognises that. There's an ask that we devolve much more responsibility for workforce and training strategy to local systems rather than it being done once at national level, because while workforce issues are playing out across the country in a way that means everybody's struggling, the reasons for it are different. So the reasons why it's hard to recruit in very deprived areas are different from the reasons it's hard to recruit in big affluent cities, and we need to have solutions that match that. But you're absolutely right, it's a key issue for us, and there is work being done.
Yeah, Amanda, I understand the thing that you mentioned about kind of this being devolved more to sort of system level. Locally, but some things do need to be done nationally as well.
And they are. So Julian Hartley is the Chief Executive Leeds, but people may remember he used to work locally, is leading a national workforce implementation plan and strategy, which is due to publish at the end of March. And that picks up lots of these points. But, you know, you're right, that's our issue.
Thank you.
Finally on this item, Sue.
Yes, thank you, Chair. So, speaking on behalf of all the health watchers at this point, obviously a key theme throughout the entire plan is the involvement and engagement of people, and it's absolutely essential that people are involved in thinking about the implications of the change process and what that might mean for them and how and where they receive treatment. So we're very, very pleased that Health Watch England has recognised that, and that each of the health watches across England are going to be doing some engagement with people in local communities. And I've this morning been discussing that in a little bit more detail with Neil Greaves, who heads up on comms and engagement for the ICS. And what we think we need to do, and what I've always said, is unless people understand what the experience of that change might be, it's difficult for them to imagine what that might feel like. And so we need to involve people in shaping some of the changes and bringing their concerns to the table. So the engagement will take the form of understanding what's important locally in each geography, but also what's important in terms of the pathways associated with each type of condition that people are experiencing. And we're hoping to carry out some focus groups as well as some generic engagement. There are some set surveys that have been agreed by Health Watch England, but which we will probably change to be more locally suitable, actually, because it's very important that what we find out within Lancashire and South Cumbria matters for people in Lancashire and South Cumbria, and that it's useful for those people that are making the decisions around how those changes are delivered. So if people would like to talk to me about that, I'm really happy to make sure that we shape that engagement in a way that's useful, both for representatives around the system, but also really importantly for people in communities, so that we hold the focus groups where it matters and where people have got opinions that they want to have shared.
Sue, thank you for that. That's more information, hasn't it, that's just come out in terms of Health Watch's role. I think there is the recognition around the table that whilst we might be talking about some of these broad themes, workforce or the development of neighbourhood working, the differences between local neighbourhoods and the opinions of local people need that focus in the individual areas. And I think whilst colleagues are coming together here, they would have the commitment to work on their own neighbourhoods, and that with the local health watches as you see fit. And then we might bring some core messages back up to this group, but equally we'll have lots of local discussion as well. So helpful to hear that balance between bringing together and doing local is being taken forward in that process.
Thank you. Well, this is obviously a really significant plan, and no doubt we'll be returning to elements of it later. I was driving here today. I heard the Care Minister on the radio say that the social care plan will be published very shortly. It's been long awaited. There have been other distractions, as we will know, within the Parliament, but the impression given that within the next month or so that will be published. So the combination of these two together will be really important. Okay, well, thank you for that. My apologies for not reading out the apologies earlier on, so I'll read them out now if I may. We had apologies from Gora Bangi, Neil Jack, Sackthey, Louise Taylor, Angie Ridgewell, Kevin Toole, Dean Langton, Talib Yassim, Louise Taylor, sorry, that's written down twice, and Gary Raphael. Are there any other apologies that people would like to indicate on others' behalf? No? Thank you very much. We now move on to the commissioning policies. Just a reminder for members that these policies have been discussed in some considerable detail within individual CCGs or with representatives of CCGs in workshops and other fora. And whilst there will be little time for each of the items to be discussed here today, nevertheless, there's a lot of work gone behind them, and it in no way reflects that these are not important issues. So with that in mind, though, bearing in mind we have a limited time within the agenda, we will have to be relatively brief for each of the 7, but Elaine is going to help us through that process. So over to you, Elaine.
Thank you, Chair. Yes, as you can see from the agenda, we have a total of 7 commissioning policies to discuss this afternoon. Of those 7, only the first one, sterilisation reversal, has gone through our local Lancashire and South Cumbria process. The other 6 are actually a response to a national ask. So what I would like to do is first of all deal with the first policy, hopefully very briefly, and that will give us more time to understand the national picture and the context for the other 6 policies, which we can then go through in turn. So from that point of view, I'd like to say very briefly that the sterilisation reversal policy has been worked up through the process that's in your paper, which we have discussed before, of clinical review, clinical and public engagement, further review, equality impact assessment, and consultation through the ICS Care Professionals Board for assurance purposes. This policy is a review of an existing policy, so it's not a new policy across Lancashire. And in fact, that process that it went through did not identify any changes necessary as a result either of changes in clinical evidence or in response to stakeholder engagement. So as a result, the policy that you have before you to ratify today is, with the exception of a few changes of wording just for clarity purposes, is actually unchanged from the existing policy. So I'd like to take any questions on that, and if there are none, ask you to consider whether you're willing to ratify it on that basis.
Okay, so are there any questions on this policy? I'm looking around, I don't see anybody. So if that's the case, are we happy to agree to ratify that policy? All those in favour? Anybody against? Okay, thank you.
Okay, thank you very much. So the other 6 policies, these are here before you today as the first part of a response to a piece of national work called the Evidence-Based Interventions Project. That's a national project that's been headed up by NHS England with a number of other stakeholders such as NICE and NHS clinical commissioners. And the aim of that project has been to look at how the NHS gives best care, best value for its resources by making sure that what we are commissioning and providing to patients is, first of all, clinically effective, secondly, safe, and thirdly, makes best use of the clinical time that we have by ensuring that we do the things that get most benefit for our patients with the clinical capacity that we have available to us in the system. So there have been 2 major threads to this work at national level. The first one actually came out last year, which was around items that were no longer to be routinely prescribed in primary care. So that was focused on medicines. What you have before you today is the first part of the other arm, which was looking at procedures, so interventions, types of surgery. What this programme did was identify 17 procedures where it was felt that the NHS should take a consistent stand across the whole of England and should adopt certain criteria for when these procedures should be carried out on patients. And as I say, that was very much around looking at what the evidence was for the clinical health outcome, the health benefit that patients might achieve from having this surgery versus any potential harm for the fact that we were intervening in a surgical manner at all. And where the evidence had moved on, perhaps, because a number of these procedures have been part of the clinical pathway for quite a number of years. But as time has gone on, sometimes there's been new interventions have come on stream, which are actually potentially more effective or less invasive, less potential harm to patients. So in that environment, that context of changing clinical practice is what's prompted this work, alongside the need for the NHS to be very clear that everything that we're doing, every NHS pound that we spend on interventions in this way is likely to have a benefit for the patient who is receiving it. So that's the context. As I've said, what was published at the very end of November, so very shortly before Christmas. And the guidance that's come out actually covers 17 procedures in total. You have 6 before you today, and I will tell you later on where we're at with the rest. The 6 that are before you today, we were in a situation in Lancashire and South Cumbria where we did not have region-wide commissioning policies already in existence. And what NHS England said as part of this work was that the NHS was being mandated to follow this guidance, and that if we did not have a policy already in place that was at least meeting what they had come out with, if not went further, then there is an absolute requirement on the NHS to adopt the policy by the 1st of April. So as the policy group and Rebecca and the policy development team had to do a very rapid piece of work to understand which of the 17 policies came into that category for us, and that resulted in identification of the 6 that you see before you today. So because NHS England had done this work in some detail, and they had done an amount of evidence review and engagement with clinicians and the system and the public through their process, we were in a very different position when we're thinking about how to adopt that through Lancashire and South Cumbria. So what we did do was we took the view that we were still expected to think about potentially quality impacts, and also to think about any local situations or reasons why we might want to do something different from these policies. So we picked up these policies and put them into our process at the point of clinical and stakeholder and patient and public engagement. So the difference fundamentally is that on this occasion, the evidence review for most of the policies is entirely the NHS England evidence review. And what we've done with our engagement is made our clinical and patient and public community aware that we were being asked to adopt these and asked for commentary. We weren't in a position to make changes which would increase access compared to what NHS England were asking. We do have the freedom to potentially further restrict access for these 6 policies, partly in relation to just the timescales involved in getting something in place for potentially for the 1st of April. The policy group felt that the right thing to do was to adopt the national policies at this time. That does not stop us potentially coming back and revisiting that as part of our routine review processes in the future. I will come back later on and just mention a couple of things. So we did get some helpful feedback from public and from clinicians about the clarity of the wording in some of the policies. So we have added some language to it, the EBI guidance, but it's there for clarification purposes, which I think was really helpful to have that opportunity to engage with our local clinical and public participants to be able to do that. So that's the general context of where we're at. And as I say, we're at the point where today we needed to come to you with these 6 policies in order to be compliant with the NHS England instruction to have policies for all 17 procedures in place by the 1st of April. The other 11, I'm going to get my maths wrong here. The other 11 procedures, we're in a situation where we do already have a policy in place. 3 of those procedures, we have a policy already in existence in Lancashire and South Cumbria which is fully aligned with the NHS EBI policies, so we don't need to take any action on that. We have it on record through commissioning policy and now here that we know that that's the case, so we don't need to bring that back for anything because it's already in line. Excuse me. That leaves us with 8 policies. Those are policies that actually we already have in place in some way, shape or form in Lancashire or South Cumbria. And what we need to do is take a little bit more time to just look at the potential differences between our current policies and what NHS England are saying. So it is our intention to have completed that work by July. We're hoping to get 4 of those 8 policies to the next meeting in May, and the final 4 with you in July. But we are already compliant with NHS the England EBI policies because we have policies in place which are close enough that we didn't need to take action before the 1st of April. I'm going to pause there and just check that everybody's following that. Is there any questions on that before we go into the specific policies?
Yes, it's really a generic question which might affect some of these more than others. Although obviously all the policies are, as you say, clinically effective, safe, efficient, and from a public health point of view, support them. One of the questions is, some members of the public may wish to have those, even if they aren't clinically efficient, evidence-based or effective. They may wish to have them for cosmetic reasons or reasons of personal choice. If we support the policies you're going to describe, we will be saying there is some restriction in access to those treatments and interventions by the NHS. But people who can afford it may well be able still to buy them. The only way we could assure equity is if we say no one who has an NHS contract should be also offering those services on a private fee basis, and no NHS estate should be used to provide those treatments and interventions on a private fee-for-service basis. Otherwise, what we're doing is restricting, for good reasons, some of those interventions for those who can't afford to do it privately, but allowing NHS resource to be mobilised for those who can afford to pay for it.
So, I mean, that we cannot make. We can make prioritisation decisions around what we spend NHS money on in this part of the country, which are in line with national policies. What you're saying is a hugely, it's a political decision. Were the government to decide that no one could work for the NHS and privately, that's effectively what you're saying. That is a whole long argument, not a decision we could make. We could equally say no one can have a Bentley till everyone can afford one. It's the same thing. We live in a society where people with a lot of money...
Providing healthcare is not the same thing as owning a Bentley. Let's please stick within reasonable...
What we're saying is that we are unable to form what you're describing as cosmetic activity because people who can afford cosmetic surgery can have it and not everybody is able to do it. But that's a political decision. We can't make that decision here.
No, but I'm happy that anybody can choose to spend their money on those things. What I am arguing, or what I'm asking is the NHS, in its use of its own staffing and its own resources, able to resist a two-tier access to those services being facilitated?
We are able to stop NHS staff and resources being used while they are working for the NHS, using NHS resources, and that's what we're proposing to do. We cannot stop NHS employed staff in their own time offering services privately. And that, if that were to happen, that would have to happen nationally.
So one more contribution on this, and then I think we better move on to the sixth.
I understand about the point about not necessarily being able to erect about the use of private care, but I suppose another way around that, given that we're talking about an integrated care system, is there not the opportunity to, might be the wrong word, dictate to hospitals, for example, that they should all be, if they're going to allow their premises to be used for such private care, that they all ought to be running to a similar kind of format cost, so that there's not disparities between different organisations.
Surely the hospitals are the NHS resource.
Yeah.
Indeed.
I'm sorry, I mean, we can't have a cross debate like this, Dominic. Thanks for throwing that pebble or rock into the street. It is an important political issue, but nevertheless, specifically on this item, I think we perhaps need to move on. It's a point that we've fairly made.
Can I just say then, what we need to be clear that we are rationing for the poor.
We are prioritising how we use the resource we have.
But not for the whole of society.
This is saying that what we are doing is prioritising how we use our resource, and what we are saying is we will not routinely commission a range of procedures which have been found not to add clinical benefit, and therefore those procedures are less of a priority for us than things which do offer clinical benefit. We've got to make sure we concentrate on what decisions we can make here and what are national governmental decisions.
Okay, so that's what we will do. We'll look at the 6 items that we have now. We've dealt with the first one. We will deal with each one briefly and then have any comments on the individual ones, and then agree or not agree to what's been put forward on each of the 6. And we need to do that in about half an hour maximum. Okay. Thank you very much.
Thank you, Chair. I'll move us swiftly on then to specific policies. I will start with the chalazion removal policy. So this is an entirely new policy for the whole of Lancashire. It relies entirely on the NHS EBI evidence review and criteria recommendations. We really didn't add any content to this policy at all. So I'm happy to, if there are any questions, to try and answer them with Rebecca's help, but certainly would just actually like to ask your views on ratifying that particular policy.
Okay, so any questions on that particular policy? No. Can we then therefore vote if we are to ratify that policy? All those in favour? Anybody against? Thank you.
Thank you. The next policy is haemorrhoid surgery, and again relies entirely on the EBI guidance, evidence review and recommendations. The only material, well not really a material, but the useful change to know about that we've added to that policy is we've added an appendix, because as part of our clinical and stakeholder engagement, we got commentary back that some of the definitions weren't terribly clear. So there's an appendix to that policy which gives clarification on definitions and how to grade the severity of haemorrhoids. So other than that, it's entirely the national policy. Are you happy to ratify?
Any questions, comments on that one? No. Do we ratify that then, please? All those in favour? Anybody against? Thank you.
Okay. That brings me on to the policy for release of Dupuytren's contracture in adults. This policy has a slightly different context because 2 of our CCGs already had a policy with similar scope, although not exactly the same, and that was Chorley, South Ribble and Greater Preston CCGs. So this policy is entirely new for the other 6 CCGs. And will be a slight change to the Chorley and Preston CCG's policy, and that's in relation to the inclusion of the potential to aspirate.
That's actually the ganglion.
That's the
policy.
ganglion one. Sorry.
The Dupuytren's contracture is a new policy for all
for
8
everybody.
CCGs.
Sorry. That's me getting my policies mixed up. My apologies. So that one's completely new for everyone and is entirely on EBI. So if you'd be happy to ratify that one.
Can we be absolutely clear? Just
yeah, my apologies. I've skipped a paragraph. We are talking about Dupuytren's contracture, which is the entirely new one.
Okay. So any comments, questions on that policy? No? All those in favour of ratifying that? Anybody against? Thank you.
Okay. So that gets me to the policy for surgery for snoring in the absence of obstructive sleep apnea. Again, this is a new policy for all CCGs except for NHS Chorley at South Ribble and Greater Preston CCGs. The policy that's been presented to you actually is aligned with that existing policy as well as with the EBI. So on that basis, I would like to ask for it to be ratified.
Any questions or comments on that? No? Do we ratify that? All those in favour? Anybody against? Thank you.
Okay. That brings me on to the policy for excision of ganglia and mucoid cyst, and this is the policy which is new for everyone apart from Greater Preston and Chorley South Ribble CCGs, who had an existing policy with similar scope but slightly different commissioning position. And the difference was that the potential to have the ganglion aspirated, so to have that rather than going straight to open surgery, wasn't previously included in the Chorley South Ribble Greater Preston CCG policy. The commissioning policy group worked with those CCGs to just understand the rationale for that, and actually the CCGs indicated that they were happy to move in line with the EBI guidance, and therefore the policy that's before you is entirely in line with the EBI position. If you're happy to ratify that.
Okay, questions or comments on that one? No. All those in favour of ratifying, please show. Any against? Thank you.
Okay. Finally then, we come to the policy for arthroscopic shoulder decompression for the management of pure subacromial shoulder impingement. I've left the best one till last, you can tell. This again relies somewhat on EBI, but was another policy where Greater Preston and Chorley South Ribble CCGs already had an existing policy. Now, the situation here was somewhat more complex because the scope of the existing policy was different to the EBI policy. And some of the criteria around the conservative management that you should undertake before moving to surgery was more specific in the Chorley and Preston policy than is currently the case in the EBI policy. So policy group felt that actually it was more helpful to have the additional language in our existing policy, so we consulted on the adoption of that policy across the whole of Lancashire and South Cumbria, while making it clear to people that that would be still in alignment with the EBI. It's just a little bit easier, we think, for clinicians and patients to see exactly what it is that's being commissioned. So from that point of view, that's the only one that doesn't rely entirely on the EBI evidence review, because it does rely on the work that was done for the Preston and Chorley policy as well. On that basis, I'd like to ask for it to be ratified.
A general question. I'm happy with the policy. How are you in a position that you will be able to audit it and ensure it's enforced? And have you given any thought into our previous discussions as to how that's sort of laid out in contracts with hospitals to ensure it's complied with?
Yes. So I skipped over in the interest of time, but part of what NHS England have done is going to be impacting on the payment by results tariff, so the way by which hospitals are paid for their NHS activity. So specifically for the snoring surgery policy, that policy says that that intervention is not felt to be clinically effective in patients without sleep apnea. And so they're actually going to change the tariff to make that zero tariffed. So trusts would not automatically do it. What they can still do, which is the case for every single policy we have, regardless of its origin, is to make an application for an individual patient to have the surgery based on clinical exceptionality. So that's one thing. The other thing is to say again that as policy group, our full name is Policy Development and Implementation Group. We have been developing with analyst colleagues in the CSU for a number of months how we can get data at an appropriately granular level to understand the impact of all our policies. We've taken some of that to the Finance and Investment Group for the ICS already to make sure that they are fully cited on that. So as we implement these policies, we will be applying that methodology, taking it first of all to policy group and then to the FIG for them to have oversight. If there's anything there that we feel is actually not in line with expectations, that might be one of the things that would prompt a review of the policy, or certainly would prompt further discussion on how well the policy is being followed by our providers.
The trick here is not so much what's our enforcement process, but actually how well are we disseminating amongst people who are practicing in these clinical areas about what the policies are, so that they're giving the right information for patients, so we're not referring people and then getting them sent back again. So the trick is getting all of the clinicians understanding and working in a way which aligns with this.
Yeah, and Rebecca's just reminded me actually that for the case of the EBI policies, NHS England is setting up national monitoring at CCG and provider level. So some of the information that's in the paper around the expected changes in activity, that has come directly from NHS England, and they are setting up national dashboards, and we've been doing work locally to make sure that our monitoring is monitoring the same things that they are monitoring, so to bring those two together, so that there will be quite considerable scrutiny on these.
Jeff.
Thank you. I know you've done a lot of work on this, Elaine, on the shoulder one, and I know I've seen it before, so I should know the answer to this, but you know, evidence is evidence, but evidence isn't always absolutely perfect, and sometimes you feel a little bit better if you know what somebody who works in the field says about this. So have we got any feedback from the clinicians who do this procedure in our area and say, yeah, I agree with this? Or have we got anything like that? Or rather than the national evidence?
Yes, we did do local consultation. I'll let Rebecca tell you a bit more.
We did do local consultation specifically at a Lancashire and South Cumbria level for this, but also it might reassure you to know that when the Chorley and Preston policy was developed, which this is using as a foundation, there was extensive consultation done, and the policy was actually worked up with some of the orthopaedic surgeons from the trusts within the region. And again, when we did the Lancashire and South Cumbria level consultation, there was support, and there was also recognition that it was aligned with the national direction of travel.
That's fine, thank you.
Any other questions, comments on this one? Oh, sorry. Yes.
Sorry, it's more of a general question. Obviously, West Lancs is cross-boundary, so for instance, Southport will look at Merseyside policy as well as Lancashire. So I was just wondering, Elaine, is there an opportunity to work more closely, given the CSU covers that area? Can we start to develop policies jointly going forward?
Yes, there is an opportunity already well recognised and discussed, and as you say, as the CSU, we have involvement in both regions, and yes, the short answer is yes, that's the intention. So, you know, we cannot always ensure that the final policy is exactly the same, because part of the reasons why individual CCGs might make different decisions is about their local needs and how they prioritise access to one service over another. But we've already aligned things like our evidence review and our processes so that they should be entirely similar. Okay?
Oh. I didn't switch my microphone on in order to knock my glass over, but I have. So two things, I suppose. One, that what we're demonstrating this afternoon is that we are beginning to take more and more consistent decisions around commissioning policy locally, and in this particular discussion, we're doing that nationally. Could I ask a question? You've referred a couple of times as we've been going through this to Preston and Chorley having had predecessor policies. In the group of policies that are going to come to us in May and July, do we know yet whether there are pre-existing policies in some areas?
Yes, sorry. All 8 of those areas, there are existing policies across Lancashire and South Cumbria. What the work that we need to do is to just go under the surface enough to be clear whether they're aligned and whether any differences would be appropriate. So, yeah, there are existing policies.
Any other questions or comments? Jeff?
I've got a general question after we've ratified this, or do you want it now?
You can take it now. So most of these have been general. We'll take it.
Okay, it's just a simple process, and that is, so we ratify all these policies, these no longer are done, no longer paid for. There'll be some patients that have, prior to us ratifying these, been referred but not seen. Some will have been seen and listed for these procedures. Now, I imagine the ones who have been referred and not seen, we may turn them back, I don't know, but what about the ones that have been listed? Are we still going to allow those to go through if the patient's been promised a procedure?
Yeah, our approach across Lancashire and South Cumbria for all of our policies since we started this work around implementation has been that if a patient was already in the system, so partway down the pathway referred, even if they hadn't yet been seen, then they would be treated under the policy that was in force at the point of their referral.
Okay, is there anything else anybody wants to raise of a general nature or on this specific item before we vote on it? Jerry?
It is very much of a general nature. I was reflecting back on my earlier comment about behaving the system working differently. There was a comment about saying, you know, the traditional approach as a commissioning system would have been to introduce the policy, we'll then look to enforce the policy, we'll then set up contracting processes to monitor activity, we'll then set up contracting challenges with the provider to then challenge the provider. If ever there's a good case to saying, actually, can we move these from being commissioning policies to NHS policies for Lancashire and South Cumbria, there's a good case for it. And if we can move these on to being clinical policies that are owned by the whole of the system, what a wonderful sign of a step forward. I think 2 things with that. One, we get much clearer communication with the public around these policies, and secondly, we actually have the whole of the clinical community supporting the education and discussion with the public. So really a plea for, we need to move these on from commissioning policies to something that becomes something owned by the NHS and the system, and therefore the challenging and questioning whether the activity take place or not becomes something that we can avoid and focus on the more important things.
Okay, it's a general comment rather than a question, I think. Yes? Yeah. Yes, that's fine.
I've got a slight problem with that, gentlemen. You cannot just ignore it having adopted the policy. If people carry on doing the procedure, something has to be done about it, either through a contract or through a disciplinary process. You can't just ignore it and say we're all pals, but carry on doing it.
Again, my reflection on that is my desire and hope that the NHS is mature enough to move on, that the historical, there is a incentive to take forward the activity is no longer there, and actual clinical leadership and clinical responsibility recognises where something which is not clinically appropriate or seen to be of clinical value in the NHS, the whole of the NHS recognises that and takes that forward. But I would agree, if that isn't happening, then there has to be a process by which we are challenging ourselves collectively as trying to behave as a system rather than a traditional commissioner provider.
Okay, so in relation to shoulders, which was the last item here, are we happy to ratify? All those in favour? Anybody against? Thank you, thanks very much. There was an additional item that Elaine, you wish to raise.
There
at
is.
this point.
Yes, thank you, Chair. Committee members may remember in our October meeting you ratified our glucose monitoring policy as one of the set of policies that we discussed that day. That policy included a number of devices within it, some which are known as continuous glucose monitoring policies, and another one which is first of its kind, known as a flash glucose monitoring policy, which exists as the brand name Freestyle Libra. You may also recall that a matter of days after that committee meeting, there was a national announcement that the availability of Freestyle Libra would come under national arrangements from the 1st of April this year. So we have been waiting with bated breath to understand what that would mean and what those arrangements would be. And about 11 o'clock this morning, NHS England issued a statement around that. So we haven't had time to look at it. It's fairly detailed, and colleagues in the medicines management team are having a look at what it might mean. Wanted to first of all make the committee aware of this, but also to say that because of the timing of these meetings in relation to the 1st of April, it may be necessary for us to take some action in advance of the next committee if the arrangements need to change. So our policy gave access to this device under certain conditions and clinical criteria. What we don't yet know is whether NHS England's clinical criteria will be the same or different. So we hope that we should be able to be in a position to tell the policy group when they meet in about 3 weeks of exactly what we think to do. And so I really wanted views on whether you would be happy for your representatives who attend the policy group to take the decision on what we do. I think we may need to have a temporary statement out next to the policy and then bring you that policy back, a revised version of it in May in addition to the others, because it's one of the things that's in that policy. It's not a standalone policy, so it's not as simple as just withdrawing the whole policy. So it was just for, I guess, awareness raising at this point in time, and to ask you to give that mandate to policy group to decide the best way to manage it on 1st of April, or whether you want us to leave things as they are until your next meeting in May.
Okay, any views on the process that might be followed to get to a decision on this before the 1st of April, which suggested delegation to other individuals? Yeah.
Chair, can I just note that I have to abstain from this as I have personal interest.
Okay.
I got the impression from a friend of mine who suffers with this disease that we're actually tighter on this than other places with regard to giving children access. Am I right or wrong? I got the impression our classification was tougher.
Our classifications are, okay, a bit of context. That original, when that device came out, it was much publicised because it's the first device. It's a different way of measuring glucose. It's not actually blood glucose, it's a sensor that goes on your skin. And so there was a lot of noise about it, and there was one of NICE's regional medicines optimisation committees did a very, very rapid review of the evidence and came out with some recommendations. Those recommendations have not been adopted consistently across the NHS in England. Some parts of the NHS in England have not made this device available at all. in Lancashire and South Cumbria, we felt it was not appropriate to just not do it because actually the evidence is very, very early days. The device has only just become available for general use. So the evidence of which patients might benefit from it and for whom it might actually have the kind of impact that was vaunted in the press, if you like, is pretty patchy at the moment. So our process we went through our standard process and applied our standard test, if you like, of the strength of evidence. And on the basis of that, the criteria that we have are a bit different to the original national recommendations. So they are slightly tighter than what some would say is the ideal because there was a body that came out with that a number of months ago. But actually, compared to the rest of the NHS, I would say we're probably somewhere in the middle. I wouldn't like to guess where. But all of that will be superseded. And actually, I think the reason for that is that some parts of the NHS chose not to make it available at all. So from our perspective, I think we took the right line. But we'll have to wait and see what NHS England is saying.
If the national guidance is such that it opens this up to more patients, I'm in favour of you doing it quickly.
Well, yes, and it would be 1st of April.
Just trying to keep this simple. I'm very mindful that there are a lot of people out there who are very interested in this subject. My plea, if we have a policy in place today, going back to the earlier comment that Jeff raised, is surely we have to follow the policy that's in place. I would be very happy to support saying that if there's additional evidence that may warrant us making a rapid change, then we should support the process to do that. But I just want that, for me, there was an absolute clarity that if we have a policy in place, surely as a committee we have to recognise that policy continues to be in place until we change it.
Okay. I guess part of our difficulty at this moment sitting here is we know that NHS England have said something and they have made a commitment for something to happen on the 1st of April. Until we fully understand what that is and what the mechanism for it is, it may be that it actually makes it available by a different mechanism and our policy becomes moot for that reason.
Can I just suggest that if the national guidance comes out, which is less restrictive and opens it up to more people, that we delegate responsibility to Phil and Andrew to sign off an amendment to our policy to agree that.
Yeah, that would be great.
If a national guide comes out which is more restrictive than our existing policy, we bring it back and discuss it further about whether we wish to adopt it. Yeah. There's less rush then. Yeah.
And ratify it in May.
I would hate our patients not to be able to access something that there have been national announcements about from that date. Okay?
Yeah, that would work well, I think. Yeah. Thank you.
Are voting members happy with that suggestion?
Okay.
Okay, all those in favour? Anybody against? Thank you very much.
Thank you.
Thank you.
Yes, I am. Yes. My name is Claire Kindness-Cartwright. I'm Senior Programme Manager on the Lancashire and South Cumbria Stroke Programme. The paper that we brought today is a very brief update in terms of the business cases which are going through individual CCG governance processes currently around integrated community stroke rehabilitation. We provided reports to the November Joint Committee which provided a full stroke pathway update and gave early indication of some of the critical decisions that we're expecting would be needed over the coming months, with the earlier of those decisions being around integrated community stroke rehabilitation. In February, we also provided a further detailed report just highlighting how the integrated community stroke rehab fits very, very clearly in the NHS long-term plan, which was published in January, and also the essential role that plays as part of the pathway in terms of reducing variation in access for the population of Lancashire and South Cumbria, which currently exists, and also the crucial role in terms of enabling the implementation of an ambulatory model and hyperacute stroke care further into the future. Without the integrated community rehab, it will be very difficult to effectively implement those elements of the stroke pathway. On page 2 of the paper, we've provided the update provided by CCG colleagues in terms of their business cases and the decision-making expected at the various forums over the coming weeks. As you can see, we have 3 of the areas who are expecting decisions to be made during March, and 2 of the other CCG areas expecting decisions to be made during May. So really, the paper today was just to provide the update that we'd agreed at the February Joint Committee meeting, and just to give oversight of the decisions that are expecting to be made within CCGs over the coming weeks. So Joint Committee is asked to note the update and ask all of the CCGs to include an agreed level of investment in their operational plans for 2019-20. Happy to take any questions.
Okay.
That's very brief.
Thank you. Any questions or comments on that? Jerry again.
Yeah, I think first of all, recognition of a huge amount of work that's gone into this, and the recognition of the expectation as part of this of the NHS plan. As it says here, we are very much committed to including the investment in stroke services within our planning process for 2019-20. I think it is important that I stress that our ability to define an amount and an absolute commitment depends on how we work as a system together to recognise the priorities that also exist in mental health services, learning disabilities, children's services, primary care, community services, and every other part of the system. So I think I'm very comfortable with the proposal in the paper, but I think there has to be a recognition that we have to ensure that we get the balance right in terms of where we put the investments, taking into consideration all service areas, not just one.
I just wanted to make a comment that I think, I mean, there's a lot of work gone into this stroke programme. It has been identified as a priority not only for all of us, but for in the national plan, it's a priority area. If anything, reinforces the need to be able to make a single set of commissioning decisions at ICS level. It's the hoops we're having to jump through around making decisions around something we've already agreed we need to do jointly and do once, and you know we can't even time one little bit of that within months. So I think you know it really reinforces the need to be slicker about making important decisions about things jointly.
Anybody else on this? The report has 2 recommendations. One looking at the content of the update, and secondly to ask each CCG to include an agreed level of investment in community-based stroke rehabilitation services in the CCG operational plans for 2019-20. That's it. Ask all those in favour of that. Please show. Voting members. Anybody against? Thank you very much. So that's agreed. Thank you. Thank you for that.
Thank you, Chair. So just by way of confirmation, obviously this committee meets on the basis of an agreed delegation of its activity. So it has a work programme and takes decisions when all 8 CCGs agree that they wish to take the decision in this place, as opposed to taking decisions in local governing bodies. Just to confirm that I've started a dialogue with a number of colleagues leading work across the system, leading collective work, to understand whether they wish to ask for the Joint Committee to take any decisions during 2019 and 20. So effectively a work programme for the committee. I'm asking them to be as precise as possible about what they might ask for, rather than give a generic permission. So commissioning policies becomes a very explicit area of work, and we're clearly going to add that to the work programme. So there's just a period now of asking for proposals and then testing those for their specificity. We obviously then need to go back to CCGs to ask for any appropriate delegations. So I just wanted to confirm that we may well have a draft programme by May, but we may also be in a process of asking for delegations by May too.
Okay, Andrew, thanks very much. Anybody want to comment on that or ask? Sure. Yes?
I suppose just added to that, that if there's going to be a designated work programme at ICS level, are there resources you will be required from CCGs to operate that?
In general, Jeff, the work programme is built up from the combined commitment of people working in CCGs coming together. So there are some people working with project management roles, and they're doing that work very explicitly on behalf of everybody. There's a dialogue that the ICS team are having with individual organisations to make sure there is a resource commitment for those priorities. But in the main, a lot of the work is led by leaders around the table and supported by colleagues from across the system, and that's what makes the collective effort.
Cost of doing things where we are doing them once truly is part of the ICS budget, and Gary Raphael has proposed that all the CCGs understand where any contribution is, and that's been agreed.
Okay, anybody else? Yes.
I think just adding to that, there's also work going on across CCGs and the commissioning support units to look at the totality of resource that's needed. Goes back to Jeff's point about how we do things differently with the resource we've got that meets these priorities within the long-term plan. Not just with the emerging ICS priorities, but ICGs as well. But that work has started.
Okay, thank you. Anybody else? Okay, thank you very much. So we now come to the point of the meeting where there's an opportunity for members of the public to ask questions in relation to any of the items on the agenda today. We usually ask that you say who you are and who you represent, but you don't have to, but it might be helpful if you were to do so. So anybody who'd like to ask a question? There's a gentleman at the back.
My name is Nick Fogg. I'm from 38 Degree Platform Files and Wire. I've got two questions arising from what Dr. Doyle was outlining from the NHS long-term plan. You mentioned, Dr. Doyle, something in connection with the streamlining of commissioning, that a single CCG would be the way in which they were considering for each integrated care system area. Have I got that right? That's my first question.
Is that in the future there will be the expectation that providers and commissioners jointly make decisions about a place. So if you take Blackpool Wire and Fowl, there's an expectation that the commissioners on the patch and the providers jointly make a lot of the decisions around the priorities, the strategy, the plan for delivery of some of the objectives. There are still some statutory responsibilities of commissioners which legally only commissioners can take. So things around procurement, for example. What this is saying is, while most decisions will be made jointly, locally, between providers and commissioners, there will be streamlined commissioning arrangements, and they say, and typically, and don't underestimate how much time and thought went into that word typically, there will be a single CCG for an ICS area. That's about having strategic commissioning approach for those things which legally and statutorily have to be decided by a commissioner only. So it isn't, even if we were to implement that very quickly, that is not taking away local decision making, local planning, local prioritisation, local decisions on how resources are applied in each of our places. It's talking about how statutory organisations are configured to meet the legal requirements. We've also seen published last week some legislative asks around some legislation that may need to be changed to enable all that to happen in a much more streamlined way.
So the existing CCGs will continue then, but there will be a sort of strategic CCG sitting at this level. Is that right?
There isn't a plan for what will happen in this area yet. This has just come out in January. We've started having discussions. But what that's saying is not that the existing CCGs continue. What it's saying is there will be, CCGs will continue but cover a bigger geographic area. What we're doing at the moment in this environment is we've continued with 8 CCGs, but for decisions which need to be made strategically across the patch, we formed a joint committee in order to jointly make those decisions. So that's a sort of halfway house from where we started with completely separate decision making to what the long-term plan is saying will typically be the configuration in the future.
Are they saying that the typical configuration would be just one CCG for each
Yes.
each
Yes.
commissioning area?
Yeah.
So the CCG system generally is going to be swept away.
So what that is saying, which is very different, we haven't made any decisions locally about what we're doing, but what the long-term plan says is CCGs will continue, they will just be much, much bigger. So instead of having almost 200 across the country or just over 200, we'd have a number that's the same as the integrated care systems or STPs. So what's that saying? If we applied that literally to Lancashire and South Cumbria, we would have one CCG instead of 8. That's what that says.
Is there a time scale that they're thinking about for this?
Well, there isn't a timescale in that strategy document, but we're expecting a long-term plan implementation document out shortly, and I don't know what that will say about timescales. Of course, that says typically. I've not heard anywhere in the country that regards themselves as typical yet, but we'll see.
Okay. The other question is about integrated care system itself. I understand that at present it's operating on a shadow form, but it goes live on April the 1st. Is that right, or what's happening?
So an integrated care system, if you remember STPs, that's sort of planning and transformation partnerships, we started off with 44 STPs. Some of the most advanced organisationally and more advanced in partnership working were designated integrated care systems, one of which was Lancashire and South Cumbria, and there were about 10 first wave integrated care systems. What this plan is saying is that all STPs will become integrated care systems. I think it gives it 2 years. We're already in the designated integrated care system group anyway. So for us, this is a continuation along the development path that we've already started.
Okay. So the integrated care system, what arrangements are there for members of the public to attend the meetings of the integrated care system? And are the minutes and agendas going to be published on the internet?
So, at the moment, and as I say, we've been designated as a first wave, and we are developing a nice integrated care system structure. At the moment, we have a partnership board which includes a wide range of stakeholders, including people like Health Watch. None of those meetings are currently held in public, but they are reported into the minutes into public meetings of our statutory organisation. So the minutes, for example, are...
The full minutes?
They are full minutes, aren't they? Go to the statutory organisational boards.
Yeah.
Have you not? So, well, at the moment, they're not held in public, but ultimately, as they become an established entity, the expectation is we would need to hold them in public. But at the moment, they're not held in public.
Apart from the partnership board, there is another board, is there not?
There's an integrated care system board. Those meetings are not at the moment held in public.
In the control you've got to some extent that any recommendations from that board have to come here for ratification, don't they?
Well, a commissioning decision would have to come here, but all the decisions that need ratifying would need ratifying by the trust boards as well as the CCG governing bodies. So yes, there are controls in place. At the moment, it's not a statutory decision-making board as such, and the meetings are not held in public, although the intention is that there will be as it becomes a formal entity.
Nick, I think that's quite an important point Amanda's just made, so that where organisations are taking statutory decisions, they're doing it in public, which is the process, I suppose, that we've been established to. What we're talking about is the development of partnership working, where we're seeing that in Lancashire and South Cumbria as part of a first wave, and we're still seeing more guidance coming out nationally about how that should take place. So it is part of a developing stage.
Okay, thank you.
Mike Wedgeworth. I'm speaking from a voluntary community and faith sector background. and I wanted to ask a question about commissioning for third sector organisations. What people in that sector always tell me is that NHS contracts are about 3 foot thick, and you need a PhD to understand them. If the third sector is to make the contribution that everybody says it should be able to make, and I'm thinking not just of the smaller organisations but also the larger ones, can we expect that the commissioning process for such bodies will be changed, streamlined, made more straightforward? And if that hope does exist, is this the forum through which it might happen?
If I start the answer on that, Mike, but invite other colleagues who want to express some views from their own perspective to do so. Yes, I think there's a recognition that the NHS contracting process has become really, really complicated in recent years. And probably added to that, some commissioners have not been as effective in building relationships with the VCFS as they might be. That's why, both at the ICS level, but certainly in the local areas, there's quite a lot of effort going on at the moment to try and link up with our VCFS leaders to try and push that dialogue further. I think there's learning for NHS commissioners from local authority commissioners about how best to do that. And of course, when you talk about the VCFS, I know you know, but it's a very variable sector. So we have large national VCFS providers working with very, very small providers. And I think it is incumbent on us in terms of commissioning, but let's call it in terms of partnership work at the different levels, that we are more effective in that relationship with the voluntary faith sector going forwards. It's been really helpful to have a number of representatives in some of the developing conversation that the ICS has been having, but we know that they're doing that in local areas as well. So I think there is definitely something here about a journey with the VCFS that we need to go on as much as them.
That while we can do those things about the process, the actual NHS contract itself, which we are obliged to use, is 3 foot thick and really difficult to understand. And it's not in our gift to not use it in the circumstances where we're...
When you're talking about relatively small contracts, it's appropriate to treat it as something like a grant rather than to go through the rigmarole of expecting somebody to go through an NHS contract.
Absolutely.
Yeah, I was just going to highlight some of the work we're doing with the voluntary sector, voluntary community and faith sector. We're one of 4 areas in the country as part of a Building Health Partnerships piece of work, and that is really looking at how do we kind of understand the value that some of that commissioning work of actually using some of our voluntary sector organisations, and how do we actually understand the value of that? And that's really looking at how we work with commissioners. So there is a piece of work going, there's certainly a dialogue and a relationship building through our kind of integrated care partnerships in the ICS, and it might be something that we might want to bring back to that, some of the work that's coming out of that.
Services, you know, are they inputting these services that's, you know, that have been removed, or are they replacing services that have been removed? I mean, voluntary is voluntary, and we're grateful for their help, you know, as a member of the public, but surely we should have them services there.
So
provided and paid for, I mean, that's what you pay the national insurance for.
Yeah, we use the voluntary sector to encompass a wide range of things. When we talk about voluntary sector contracts, we're not talking about volunteer contracts as such, although we are encouraging volunteering. We're talking about things we commission from charities, the faith sector, community groups that we pay for, and they're not replacing contracts. What we are finding is it's increasingly we're doing not replacing contract. What we're doing is
I'm only asking a question.
well, and I'm only trying to answer it. So what we are doing is adding things in which we found are benefit to patients to improve their health and well-being. So things like the ability to access community groups, exercise programs, help with weight management, help to stop smoking, added support for elderly people in the community, that some of these voluntary sector groups are very good at providing, and we're doing that additionally to the traditional health things we're commissioning. So we, for example, may commission charity groups to support age concern, provide some services that help support elderly. Those sorts of services. Pardon?
What type of services?
So things like helping people after discharge from hospital. We have some voluntary sector.
or a voluntary
No,
service?
voluntary sector. They are paid for services.
No, but you would have somebody who's a voluntary sector releasing somebody from hospital. Surely you'd have a trained person who do that. You release somebody from
We're
hospital.
not talking about volunteers. We're talking about what we call the third sector, which is voluntary sector, faith sector, charities, community groups. So we're talking about big organisations sometimes, like Age Concern and the...
Catholic Church is a huge organisation that does charity. I understand that.
Yeah, but people like the Red Cross, Age Concern, Macmillan, Cancer Services offer specific services with trained staff and workforce.
Correct me if I'm wrong, the public actually pay into that in the charitable. I mean, it's financed by charity. Charity pays into the Red Cross, pays into these things, and that's what puts them in place. They wouldn't be there just with I would imagine, the contracts you're getting. We wouldn't be feeding the rest of the world with charity. Where you putting the money in.
So
I'm confused here.
We are commissioning services from some charities
What
for
kind of
which...
service? Then I keep asking.
So, Macmillan, cancer support services,
and
hospices.
How do they support cancer? You know, explain that to me.
So Macmillan is an example of a...
Macmillan are a charity, yeah, but they take nurses from the NHS. I spoke to them about it. Train nurses. The NHS trains a nurse, then Macmillan come along and says, can we take you to this job? So you get nurses leaving the NHS, joining Macmillan. So in a sense, the public are paying for them to be trained over the years, and then they go.
But actually, I mean, we could go on for ages. Those services, those charities and groups are providing really valuable services for which the NHS and local authorities pay. And for some things, we get additional benefits because groups such as hospices, for example, also fundraise in the community to provide additional benefits to patients. But some of the services they provide are by trained staff for which the NHS and local authorities pay for the services.
But the staff that are not trained, you don't pay for them, so they get it voluntarily. And again, that is the downskilling thing.
Okay, so I think that's...
I've not really an answer in all fairness. I don't think it's a good explanation.
I said clear.
That's
right.
Clear but not a good explanation.
The lady at the front.
I'm also a supporter of 999 Call for Your NHS, who currently have an appeal sat with the Supreme Court against NHS England for the implementation of your ICSs, your ICPs, which are all accountable care organisations, as everybody in this room is well aware, which is a US style of healthcare. Regarding the charity sectors, I'd just like to come back. They are the charity and voluntary sectors. Although they provide certain services, one, it does, as this gentleman was alluding to, it's you are removing the very thing that you say is the reason why we're cutting back on some services and restructuring the models that you're using, which is staff resource. So they are now going out when every time you commission a private service, those staff have had to be removed from a possible NHS position to go to that private service in the first place, therefore exasperating the whole situation of your staff issues. Secondly, charitable services are not sustainable. There was it was in Kent, and it was one of the CCGs had a charitable service which was then, it was used to replace the NHS provided service. This particular company, charity, then, because the government cuts the funding in another area that they also worked in, they then didn't have the funding to carry on doing that service. So it fell through completely, and they were left completely without a service, going through a whole new tender, expensive tender procedure yet again. So it's not sustainable. The money isn't sustainable. The service itself isn't sustainable. And although you do have a certain amount of skilled labour in there, the rest of those extras that you're talking about are downskilling, untrained, unsafe to use resource. That's my first point on that. Secondly, I was at the NHS consultation, NHS England's consultation on the removal of those 17 procedures. And there were about 20 people there from the public, because they don't advertise it. But of course, we're being part of a network looking at these changes. We told each other and we went. So we've got quite knowledgeable people. You were trying to say in the other room that I don't understand what you're saying, but it was slightly patronising. I was at this consultation, and both the clinician, the person in charge of the policy in the first place was there, and a representative of all CCGs, and they all admitted there is clinical benefit to be got from these procedures. However, to make savings, we have to start cutting them. There's also a second part in that policy, I'm sure you'll know, within the policy. It does say that there's a phase 2 and another further 17 going from the going up for consultation straight after, with phases 3 and 4 following after that. So this is like a slippery slope where these are going. And they admitted at the NHS England consultation, it is cost benefit only. This gentleman is perfectly right. That means you were all sat here making these decisions, like nodding dogs, removing these procedures bit by bit, agreeing to it, saying that you want the best for patients. You are removing these. The people, the most vulnerable in our society, the NHS and our healthcare is based on well-being and the quality of life. So just because somebody, you don't consider it affordable for somebody to have a hip replacement when they take 20 minutes to get down bloody stairs and can't go upstairs, then that's quality of life. Yes, they might be alive. And I've no question, because I've had all the questions in there and we didn't receive an answer. This gentleman asked a question and wasn't received an answer. I want you all to consider, and every single item that you remove from this, that you are removing a service to people who cannot afford to go private with it. You are creating, in effect, you are all creating a two-tiered healthcare system. And although this is political, you are compliant. You are all compliant. And it disgraces our country.
I have some sympathy. I find some of these decisions difficult, and the reason we're making them is because I don't think the NHS has got sufficient funding, and it's a lesser of two evils. By making these tough decisions, we're allowing the money to be spent on the things we think that are more cost-effective. As regards the... Well, we can't... Yes, yes. So maybe we're not making a case strongly enough for more funding. If that's the point, I would.
Is it not incumbent upon you to make the case?
But there is an argument for that. Yeah, I don't disagree with that. As regards the third sector.
We hear business case after business case of why these elective procedures, medications, actual services need to be cut, slashed, removed, not duplicated in any one area. To make it the bigger population accessing smaller services, or smaller than they are in the whole. When that access, every time you do that, and that access is removed or is harder, when it becomes 4 months to see the consultant specialist in Blackpool lung.
As I said earlier, some of our waiting lists are unacceptable, and that's under-resourcing.
The only people that can see somebody is somebody who can pay.
No, the only people... Urgent stuff is seen quickly anyway, but it means that people who aren't urgent have to wait too long. And I'd agree with you. Yeah.
Those waiting lists longer and longer because you've got...
No, I'm not sure about that, because if we're restricting access, they make them shorter.
You're only seeing the top tier of society,
Can I just ask you, by that logic, you're saying that if we stop doing surgery on shoulder procedures, you're saying that that's going to take more time for Joe Public to see a consultant, but we're actually making that consultant not do that procedure. So we're talking about removing ganglion.
for colleagues around the table. Thank you for your decisions today. Thank you to members of the public. We won't always agree, but at least you can hear us making the decisions here. Thank you.